Dr. Harper was a pediatrician, one of the founders of the population movement, and also a firm believer in prevention. He completed his MPH here at Hopkins and was appointed chair of the division and then the Department of Maternal Child Health from 1947 to 1970. And personally, I need to comment on how remarkable it is for one individual to have chaired an academic department for more than 20 years. As the biography in your program notes, Dr. Harper was a visionary teacher and leader. What it doesn't share, but I think is highly relevant to today's discussion, is the focus of the breadth and depth of his 1962 textbook, Preventive Pediatrics, Child Health and Development. And I was sharing with our guests earlier today how much I enjoy going back and rereading sections of the book before this lecture every year. So in it, he acknowledged declines in infant mortality and new treatments based on science. And he also emphasized the need to focus on emerging problems related not only to physical, but also emotional and mental health. He astutely noted that many issues at the time were newly recognized issues, such as injuries, then called accidents, but these were examples of what he called broad social problems with variable medical content, which increasingly will require joint study and action by several social agencies, including medicine and public health. I'm sure he'd be glad to be here today to hear what Dr. Willis is going to share with us. So delivering the Harper Lecture this year is Dr. David Willis. He's now a senior fellow at the Center for the Study of Social Policy, where he leads a new national initiative focused on early relational health for child health and for communities. So he's also trained as a developmental behavioral pediatrician, and he was a practicing clinician in Oregon for more than 30 years before he was wooed to the lure of Washington, D.C., where he served as the director of the Division of Home Visiting and Early Childhood Services. In this role, he did a phenomenal job of inspiring others with a vision of what it means to create environments, both within families and within communities, of what it takes for us to enable young children and families to thrive. Dr. Willis was instrumental in creating and implementing the McV program, the home visiting initiative led in partnership with his team at the Maternal and Child Health Bureau and colleagues at the Administration for Children and Families in order to meet the needs of low-income families. In this role, he played a key leading role in the design and conduct of an 88-site randomized controlled trial and an implementation study to assess and explain the impact of home visiting on its intended outcomes. He also advanced the field of home visiting as a service delivery strategy by requiring rigorous state-level evaluations as a condition of receiving federal support through McV. And his efforts further contributed to a national movement, helping us build the capacity of states and local programs to deliver home-based services for families with young children, while also creating learning communities with continuous quality improvement at its core. And finally, he has been integral in shifting the culture of home visiting and bringing stakeholders together to begin to answer questions about what works for whom, or what we affectionately call precision home visiting. Most recently, he served as the first executive director of the Perigee Fund, a Seattle-based philanthropy focused on advancing social and emotional development of infants and toddlers. And he's had multiple leadership roles within national and state committees with the American Academy of Pediatrics and served on numerous advisory boards. So we're really honored to have you here today to serve as this year's lecturer. Please join me in welcoming Dr. Willis.
Thank you, Cynthia. Can you hear me if I talk at this level? Good. It's a thrill to be here, and I'm honored to be the Paul Harper Lecturer, and with no disclosures. I had also the chance to review Dr. Harper's history, and I was 12 years old when he wrote the book Preventative Pediatrics and Child Health and Development, which is sort of core to what developmental pediatrics is about, what pediatrics is about, and what I think is the evolution of our work in pediatrics about building well-being of every baby born by intentionality. And so I'm thrilled to be a part of this, this lecture series to share with you my journey, first as clinician, then into policy, then into this space that's really looking at how do we harness the science, community work, and moving forward to build the well-being of every baby and opportunity. I want to share with you three bold objectives. One is I want you to think about a paradigm shift around early relational health, and we'll talk about that as we move forward. I want to share with you the trends I've been witnessing in the last 5 years, 6 years, in around the human well-being movement that we're witnessing. And the third, I want to talk about what I see in front of us that are really levers of moving this kind of work forward that I think will be meaningful for all of you. I'm a developmental pediatrician at heart, primary care pediatrician, just like Dr. Harper at the start of his career. And I learned every family wants the best for their children. Every family would wish to have some, at moments, additional information or supports, or at times some guidance. And that's ever more so in this nation over time. And the concept of building the potential of every baby is in front of us. And I like to say that, every baby is born with a potential, and then unfortunately many lose it. And that happens sometimes right in front of us. In our health system, we witness it, in our communities, and these are urgent calls. And I think there's an urgency to the message of how do we move forward in assuring the well-being of every family and young child build. We also know there's a very clear core story of child development. The work has been seminal to helping move the field. We like to think about the one science of early health, early development, early education. That's built, of course, on brain architecture, is built by experience. Relationships are key. Environments and genes work together. The importance of the multiple domains of human development are inextricably connected, and that toxic stress can derail it, and that there's a plasticity always at work. And how do we harness the plasticity, the resiliency potential, the recovering and the healing in every situation in front of us? It's also heartening that across the world, the sense of early childhood development is in ascendancy. The Sustainable Development Goals that UNICEF and the World Health Organization are making visible are really articulating a nurturing care framework that requires simultaneously attention to health, the attention to nutrition, to safety, security, responsive caretaking, and of course, early education. These elements of a nurturing care environment are really essential. And to see that the world's socioeconomic development view, the next generation of the world's people, as young children and babies are surviving better because of nutrition as well as because of infectious disease management, the next clear world agenda, despite the challenges of the global climate issues and migration and the like, is about human capital development, which rests upon these core principles that are related to nurturing care. I wish we could say we are doing as well with these kind of agendas in our nation. We're not. And I find it almost unconscionable that we're not more focused with a children and family agenda to take the science and the knowledge and the awareness we have, because we're losing the potential of our citizens every day that we witness, unfortunately, in front of us. And we know our children are faced with the challenges of poverty, which is increasingly being elevated in the national dialogue. We know that trajectories of human development and education start really early, and it's shocking even by age 2. We have children off point developmentally because they're not having the language vitamins or the relational environments or the safety to assure that their brain and developmental system takes place. And also, I'm deeply committed to how do we address the concept of preventative mental health that still is not quite in the dialogue. We talk about the scourge of mental illness, we talk about the suicide epidemics and adolescent depression and anxiety, but where does it come from? Why is it happening? More importantly, how do you get upstream in thinking about true prevention promotion and thinking about mental health problems as being outcomes of something? Certainly the trauma histories, certainly others play a role. The other area I've been deeply interested in is the movement around the kindergarten readiness agenda. All across our nation, parents and communities are aware that unfortunately a significant percentage of our kids are not coming to school ready. The majority of their weaknesses are often in what's called engagement and learning, or what can be thought of as social emotional development. So we have in most states, Washington is one example, but we have 27 states now that actually have kindergarten readiness measures at the entry to kindergarten at the state level The data is becoming visible. It's also true in Oregon. But in Washington State, for example, almost 50% or more of kids come to school not with the expected social emotional skills ready. Asking the question, what happened? Asking the question, why not? And we know, you all know, those kids that are struggling with social emotional weaknesses, we've got to do some reparative process on one hand, but their life course trajectory is at risk. Their third grade reading, their graduation rates are at risk, their engagement in meaningful work and jobs, their vulnerability to substance abuse. I mean, the trajectories of life get established very early, and it's a key marker to be thinking about in this population health movement and the human well-being movement. So similarly, when you think at a population level, which is, I mean, your organization, your center is so deeply focused on thinking about population, and Dr. Harper being focused on maternal child health, preventative pediatrics, the sense of really partnering with parents, seeing the potential, was a trailblazer in this view that to address population health, we've got to be thinking about partnering with families, and we've got to be thinking about the well-being of families to build well-being of children. And we know that although we have 60 to 70% of kids that are doing well, there's a huge number of kids that are still facing behavioral, developmental, and social emotional developments that are really a task in front of us. And as I mentioned previously, we know too that those children that are falling off developmental trajectories start really young. And if you look even at a population of kids at age 2, we can see that the drivers of those group of kids that are not going to be ready for kindergarten readiness, that are not in Part C, they're not in special education services because they don't qualify. But even at 2, we know some of the drivers of why children enter school not ready for learning are related, of course, to poverty. We know that. But it's also related to how much language stimulation in the relationship, shall we say, of reading to build the brain's capacity for interaction. That also is another marker of why some children are not on point. But the other is poverty's impact on food insecurity. And food insecurity is stress. And food insecurity and stress disrupt development and the relationship. And then, of course, the sense of parental mental health issues being disruptive. By and large, that's depression or anxiety, stress, or maybe the challenges of trauma, adversity, adverse childhood experiences. So even by age 2 at populations level, and we know these drivers of why children's developmental trajectories are not on point, what are we going to do and how do we think about that? We've all been impacted by the CDC work of the ACEs and the adverse childhood experiences work. Although, as Dr. West and I were talking last night, you know, adversity in terms of and trauma in terms of disrupting human development has been known for a long, long time. It has been elevated, though, into the health sector's view. And even now, we're seeing ever deeper the power of trauma to disrupt health, development, life course health, and the incredible costs, not only in terms of long-term health and disease states, but also economic costs. So the sense of child adversity captured within the adverse childhood experience has been a game changer in our awareness. But I'm beginning to think we're trying to move past an ACEs world into a recovery world from trauma. We've got to start thinking strength-based, and we've got to start thinking about resiliency and recovery, not just determining where the risks are alone, but actually partnering with families in opportunities of healing, recovery, and resiliency that are naturally embedded in communities and in populations that can be of value. We have seen that the ACE movement has actually been strong across the nation. We have 27 states now that actually are developing ACE screening within population efforts. And you now know Nadine Burke-Harris, as the new Surgeon General in California, is talking out loud about ACE screening universally within California. One part of that movement's very strong, but how do we build on top of that messages of recovery, messages of engagement, messages of participation to, again, break the cycle of how trauma and adversity disrupt development? I also think it's really important to pay careful attention to our language and to be clear about what we're talking about. Certainly, childhood adversity is any circumstance or event that pose a serious threat to physical and psychological development. Within that, adverse childhood experiences was just a subset that Vince Felitti and Richard Anda created for the ACE study. There are other adversities that are not included in the ACE data itself. Poverty as one example and others. But also think about now mechanistically, trauma within these adversities can have physiological impacts and psychological impacts. But the process of that is within that concept of toxic stress. But within the concept of toxic stress is the opportunity of the buffering by strong relationships. If one has a strong attachment and a safe environment, even in face of trauma and toxic stress, the protective and recovery opportunity when there's a strong relationship is strong. The corollary, however, is if you have weak relationships and no relational buffering, and a baby or a toddler or a 3-year-old or a 7-year-old are traumatized by some event that's happened around them, it creates a toxic stress response in their body. If there's not a buffering response or a history of protection from relationships, it can have long-term impacts over time. We're right back at looking at the relational context. One of my colleagues in Oregon, when the ACEs work first came out, became really curious about what does it mean if a parent has a history of adversity in their history and now they're parents. And so R.J. Gillespie, a pediatrician in primary care, actually started doing ACE screening at the 6-week visit with families in a dialogue with them about your history matters in parenting. If you're willing, let's consider having a conversation about that. This tool could help us begin a conversation. And that was the beginning of the sort of movement of ACE screening into primary care. That created a dialogue. Parents then, with the pediatricians in those practices, began having conversations about how do I not let my history of struggle disrupt my parenting now. So it was a sense of an opportunity of recovery. The other thing that was notable is he was able to do some just simply straightforward screening work using the ASQ and the ASQSE with this group of all of his families within his practice. And actually no surprise, but I think a little humbling, is families that, though, have adverse childhood experiences in their histories, there was a correlation to their children having social-emotional difficulties as measured on the social-emotional DHS-SE. So that's saying that adversity, unfortunately, can disrupt patterns of social-emotional development, which I think calls out, what do we do intentionally? In terms of being intentional about knowing how past history can play a role, and what do we do about promoting a strength-based approach of healing and recovery so that there's not a generational transmission of weaknesses as seen in social-emotional development. That's an area I think that continues to grow. So what do we do about this ACE and trauma and adversity challenge that is now in front of us and in the public dialogue? Well, I was excited to be a part of the home visiting work, and that work, as Dr. Benkovich mentioned, has been an accelerator of early childhood systems work and focus on trauma, recovery, partnering with families in communities for future well-being. It's too generationally focused. It works on strengthening families and the parenting practices and connecting the systems. It's not in and of itself a full solution, but the fact that it's partnering with families at the earliest period in communities is important, and it's been catalytic as an approach to looking at communities and moving towards population efforts. The concept of home visiting has been broadening to being a sense of a continuum. There's, in Oregon, there's a legislative bill soon to be passed for universal home visiting as the entry point for all families to have 1 to 2 home visits as a beginning of connecting to resources and to opportunities. So there's a movement happening around this kind of work. But also around trauma and trauma recovery is a sense of parent training programs which we have, addressing inter-partner violence prevention efforts, the key and criticalness of social supports. And as I'll say in a moment, social isolation is really a disruptor to early childhood development. You know, somebody's got to take care of the mom and the father taking care of the baby. You know, the isolation of one caregiver and one baby is not very healthy. The necessity of being of a young family, the next generation, be embedded in a complex social network is essential. So the sense of building social supports in communities, in neighborhoods, in intentional efforts has tremendous power in terms of recovery, healing, and promoting positive efforts. Youth mentorship programs do, high quality programs in childcare and home visiting, as well as early education are likewise important, and the whole concept of economic and economic development is also moving forward. We have many paths to think about prevention and a lot of work to do, a lot of work to do. Primary prevention, of course, looking at how do we address poverty, how do we address well-being in families. We think in terms of secondary prevention, of course, addressing toxic stress of known families and communities and programs in various touch points for families and young children become really important as environments, and of course, tertiary prevention activities. And I've had over this last year the incredible experience of being a part of a new philanthropy who is focused on promoting social emotional well-being of all children, recognizing that there's a field that has to be built, recognizing we have a small group of infant early childhood mental health interventionists to treat huge numbers of families struggling. We have calls in every sector of the early childhood community for people that understand infant early childhood mental health, prevention, promotion, consultation, first level interventions, interventions and treatment, high level intensity treatment, and we have no workforce. We also have no plan in place for building a workforce out of communities that are of people of similar ethnicity or community networks. The community health worker movement, the doula movement, the home visiting movement, out of communities of greatest need as partners of joining families with the concept of healing and recovery for the next generation is right in front of us. All alone the people we need that will be in our medical homes as mental health consultants for families, or Healthy Steps providers that understand the power and importance of relationships and promoting child development, or those that can provide intensive interventions with evidence-based programs that we know about. There is no workforce trajectory. There's no payment structure in place that helps support the workforce development for these various elements. I would say in terms of right in front of us, the major policy driver that's calling for direction, I call it the Blue Sky Project, is what is the trajectory of building the workforce for human capital development to heal trauma and build the next generation of children and families within this community. We have a sea of known interventions. How many of you are aware of these? These have been around 20 years of work. We know they have evidence-based. We know that they work in terms of healing, trauma recovery, strengthening relationships and attachment, some of which are home visiting, some of which are intensive treatment. But for example, child-parent psychotherapy, which is fabulous work. It takes, years of training. It's months of treatment. I like to think about it almost like being a neurosurgical intervention, meaning the amount of time, money, resources, and training to create the person who can do the work that creates the healing process. We know how to do it. But that's not going to scale. And when I was at Perigee as a funder, we were saying, we're not going to treat our way out of the epidemic. We have to have treatment. But we have to be thinking about key drivers, root analysis, what are the key promotion, prevention, and early intervention efforts that we have to bring. We've also, of course, know that this is incredibly complicated in the sense of the social determinants of health. In terms of well-being, it's complicated. The social determinants are big, from the household material well-being to, of course, the parents' personal history and their skills, and also in terms of the social fabric that families live in, the safety of community and the cohesion of a community itself being connected, but also the relationship patterns. All of these elements play a role to that nurturing framework we were talking about. But the science is clear. We know a lot. We know what development looks like. We know what interferes with it. But organizing the systems and the structures to do this work is challenging. Every community is a bit of its own story. I had the remarkable experience as first a primary care physician, then as a developmental pediatrician, then as a leader in Oregon to realize that the systems work. There were a lot of people in childcare, early intervention, early education, family support that understood that they needed to work together around communities and partnering with families in order to make differences in the well-being of children. Often the health system wasn't present. And unfortunately, over the last 2 decades, the public health system has been in recession. So the health element of the early childhood movement is begging for elevation and gain. Over the last 5 years, 8 years, the sense of the health foundations of early learning and well-being have come to be in the forefront. The sense of linking health, public health, and community activities in local supports around families is really where the movement has come and the opportunity that sits in front of us. But as this little slide up here shows, we've got to align all the quivers going in the same direction. The sense of community organizing of all these systems toward the same aim in the same direction becomes the challenge, but also the unique opportunity that we're seeing. And I want to talk about sort of actually 10 trends. It seems like too many, but there's a lot of trends that are converging around this human development activity. One is, I'm proud to now be joining as CSSP, the Center for the Study of Social Policy, who's really championed this Strengthening Families Protective Factors framework that has been a research-informed approach that has really been a view of we've got to have a strength-based approach with partnering with families. We've got to be focused on the social connections, providing the resources at the time of need, thinking about concrete meeting the needs of families. That strength-based approach has really sort of galvanized some of the early childhood work over time as one trend. The other trend I like to say is there's increasing work recognizing system building, early childhood system building. From 10 years ago, when there was basically early childhood comprehensive systems that came out of the federal government, since over the last 10 years, there's been increasing major significant federal dollars coming out to connect systems, health, early education, and communities, right, in order to be able to surround families with supports. That concept is trying to move forward strongly, and even as we speak, the INC model, which is the integrated care for children in communities, is growing as a Medicaid and community structure of supports. That's a really huge opportunity in front of us where Medicaid and the early childhood communities are trying to figure out how to work together. It's a competitive grant. There'll be probably 8 states that will be awarded. However, there is no state that can't do exactly the same thing because there's no policy barrier to linking Medicaid and community programs. This is really to push that agenda forward. And I was proud that when I was at HRSA, we worked intently with CMS about trying to push that opportunity in front of us, which is funding and sustainability for this kind of work. The second is the preschool development grants that are out as we speak. And the amount of money that's coming out of ACF into states in order to be able to organize and do planning around system building is unprecedented. And so, likewise, states are working together anew around system building and a trend that I think will pay dividends and is really important. Jack Shonkoff from the Harvard Center and many others have worked hard in continuing to elevate that there's a science of human development and that the science calls out not only brain development, but the skills and abilities of parents, which is pointing to the criticalness of the relationship. So that there's a whole body of science, and I'll talk about it in a moment, a whole body of developmental neuroscience that's pushing our understanding of human development between caregivers and young children. That's brain science that yields skills in individuals over time. So following the brain science is really important. The other no-brainer to us, but I think politically was powerful, was the sense of the two-gen movement, two-generational. For a long time, we've had programs that just touch poor kids alone without addressing the needs of their parents, and the outcomes, forgive me, were not very strong. And the call has been, whenever you're working with young children and families in programs, you've got to be attending to the needs of their families because that's the context within they live. So that sense of working simultaneously to family economic self-sufficiency and education and their well-being, simultaneously with supporting their children and their relationships becomes essential. That movement has been led by the Ascend Institute and also in the Aspen, and it is the home visiting program is a quintessential evidence of that and was called out as a top burner approach to a two-gen approach in communities, partnering with families and children at the same time in terms of improving well-being, another important trend. The other trend that's coming forth is the importance of maternal well-being. And what was it, 4 months ago, 5 months ago, where maternal mortality became into the public dialogue. Oh, thank goodness. And it elevated, of course, how trauma weathers the physiological abilities, no matter who people are, but especially communities of color and those of adversity. The weathering of the physiology creates great risk. And we know that unfortunately there are structural racist barriers in many health systems to high quality care and delivery. The sense of maternal well-being is needing elevation and is a trend that's coming forth. And in the building of the well-being of the next generation, infants, toddlers, and children depend upon the well-being of their caregiver, their mother and their father. So that movement that really starts to call and attend to the well-being of mothers, which is addressing, of course, not only their trauma histories or what their current safety is, but also their current mental status or stress state, maternal depression, anxiety, the whole movement upon maternal depression screening, identification of risk, the doula movement that is coming in about surrounding young families, young pregnant women with community supports. The power of social support in face of adversity and trauma is strong and important and a part of the movement going forward. I mentioned the trend around school readiness. I think this trend's important because it captures the public interest. Sometimes it's hard for us in health and public health to talk in ways that the public accepts, but everybody's worried about the educational ability of their kids. So it's a message strategy, but kindergarten readiness is a health outcome. And I'm fortunate, again, my home state of Oregon, Medicaid contracting with the CCO 2.0 will require that the CCOs, the Medicaid organizations, report on the improvement of their kindergarten readiness rates of their children. Medicaid, responsible in terms of the outcomes of early education and kindergarten readiness because it's a health outcome, but it's driven by the social determinants out of the community. So it's pushing Medicaid, health dollar, and early childhood system building together around managing in terms of rational ways, population risks, and improvements over time. It's another important trend. The seventh trend, which I think you all are champions, and certainly Dr. Menkovich champions, is that sense of public health and primary care linkage. Pediatrics is transforming in front of us. It has to become much more community focused and connected to communities. The days of the doc siloed in his own or her own office, not being aware of the communities are over. The sense of building the medical home linked and coordinated with community supports and services is here. And that's moving forward, I would argue, under beginning to think about local population management, the sense of community engagement, and with families, it becomes an issue of leadership in a community and a sense of sustainability over time. I've been impressed and also rather humbled about how all of us have to really be listening to parent voice and how we really have to be thinking about how all of us embrace how parents that we yearn to serve, what they actually experience of our programs and our structures and our approaches. Some of the work I've recently had the privilege of being a part of makes it clear that in some communities, the racist and structural racism and historical barriers create a disruption for families to participate with us. And we're not listening very well. Thereby, if we begin to think about, as we're doing our community system building community well-being and engaging with families, the more we absorb the family voice and have families at every one of our planning tables guiding us as to how do we best serve them and their needs rather than what we imagine, is a transformational moment. The Center for the Study of Social Policy recently did some focus group efforts with seas of families that touch systems and actually created sort of a manifesto of how to engage equity into this early childhood space. And to keep right in front of us. I mean, we're basically, most of us, of privilege. And that in and of itself creates a mindset. But how do we actually challenge the issues that occur in racism and be very intentional to listen very carefully to what we're hearing from families? Secondly, how do we embrace parent leadership at every one of our tables? And there's a movement in home visiting, there's a movement in early childhood system building, there's a movement at so many levels to bring the parent voice to planning tables and have them help lead and guide the development of how do we best serve their needs and together with us. How do we prioritize parent engagement as a major value? Not just an add-on of one person, but 2 or 3 people at the table so you don't have just your token parent, right, at your planning table, but rather 2, 3, or 4 people that are working with us so that they can help us create and move planning forward. And then simultaneously thinking about career trajectories for parents as they start to engage into participation, into roles and responsibilities in our public health movement, and what's our data. It's also exciting to me that we're actually talking about poverty and reduction of poverty. And if you follow some of the major thought leaders and then this most recent report that came out for the National Academy of Sciences, there is a pathway forward in terms of economic redistribution, of policies that could be operationalized in terms of elevating the poverty level from the very lowest, the sense of we're learning about universal incomes and the impact that has on young children. There's some research work going on now about conditional cash transfers, pay to play, shall we say. Participate with us and you can have additional income coming your way. There's a study in Oakland that's giving a college savings account to every baby born in Oakland. And then if the family stays in the city, they get another additional injection into their college savings account for their new baby as they enter the school system. And we already know that simply giving a college savings, small savings account to a baby and family when a new baby is born, it changes the future orientation of those families. They begin to have a mindset of the future for their babies. They start to have a sense of possibility. And we know that the social, emotional, and educational readiness improve. So the mindset shift of addressing the economics around addressing the poverty issue is really striking. The last trend I want to touch on is a trend that I think is important called the ascendancy of early relational health. And this comes as a sense of there's a space that's still begging where we go from the focus on an outcome of the individual to really absorbing what we know about the field of infant mental health and what we know about health, education, and future well-being are outcomes of the relational context. I'll say it again. The outcomes of health, education, and well-being are outcomes of the relational context, right? And so we've begun to think about just the concept of early relational health, which is actually a continuum from promotion to prevention to early intervention to intensity of intervention and to a field of infant mental health. This is more unifying than it is in any way dividing. It's meant to capture the fact that relational patterns drive well-being and are really essential. The science is compelling. If you start looking at dyadic neuroscience research, where there are simultaneous measures of the interactive space, you see some astounding observations that at every level of physiology, behavior, neurochemistry, chemical, biological, EEG patterns, there's a synchrony that goes on between a young child and a parent that actually develops the next generation's capacities in their physiology. It's shocking, striking, compelling, and I think signals something very important. And from a health system view, it may herald where we're moving in terms of what child health care is about, which is building through dyadic patterns a relational health capacity that we measure as individual outcomes. Last year, I saw this little report that just said, you know, we could actually look at simultaneous interactive patterns in terms of measurements. I mean, start thinking about, right now we measure growth curves. We look at hemoglobin, hematocrits. How do we measure the relational capacity, which is brain function socially, that are fundamental to these kind of efforts? Just imagine the possibility. Now, when we talk about early relational health, you know what I'm talking about.
Use this one. Wait.
But you can witness non-verbally what we're talking about when we see patterns of interaction.
Okay.
This cute little Diane.
No?
Imitation, smile, engagement, disengagement, re-engagement. Waiting for a cue, father can't stand but get involved. I mean, in a moment, you're witnessing something that you could measure,
You found something else?
you can document, and you can be reassured, or you can say, I need to know more. Similarly,
Hello.
sometimes you see patterns where you would wish there was more going on, or you would ask yourself, where's the juice between them? What's happening here? You find yourself asking questions, things you want to know, and you probably have the desire to say something. Capturing the concept of relational health, objectifying it, starting to think about interventions. It's a shift of a perception and a way of thinking. Similarly,
Can you do this? Look, kid, look. Yellow. Look at my blue. Orange. Here, hold on. Wait. Here.
you find yourself wanting to intervene or to wonder or to be curious.
Can you do it with mommy? Look. Yellow. No, look.
So you with me? In a blink of an eye, look how quickly you were able to think relationally and to start asking, are there objective measures? What do I do? Now, there are objective measures. We know there's a sequence of social emotional development. It's been well described. The late Stan Greenspan and others have articulated it. The Bailey 3 has these sequences that are well articulated in the Bailey 3 measures. There is a sequence of social emotional development that's described, that's observed, that's measurable and observable. The sequence of social emotional development in the dyadic space. It's described, it's seen, it's observable, and patterns up to age 2 and age 3. And that pattern can be seen by video. One can observe in video interactive patterns pretty quickly. And every family in most environments across this nation have a smartphone. And many are posting things all the time. And the question is, how do we capture some of that opportunity that's in front of us? So when we talk about early relational health, we talk about it being dyadic and 2-gen. We talk about it being bidirectional. Because the truth is, babies also develop parents, right? Right? Babies develop parents, and it's bidirectional. There's actually a healing force of attunement and attachment that heals and helps awaken a parent's reciprocity. There's even some evidence that the support, a strong support around a strong relationship can heal a parent's depression. The point is, around early relational health, it's bi-directional and capturing that kind of capacity. It's also foundational to equity. The equity story plays through the relationships. So even in communities of adversity and threat, there are families that elevate to true success and resiliency. Through what? The relational experiences and other factors. So the equity pattern is still a part within the relational health. All of relational health is science-based. It does recognize that there's cultural variability, but there probably is some universality cross-culturally about the brain, parent, adult, from one generation to the next, biologically, evolutionarily required patterns that we could further understand. And I'd like to say, I think it's actually a paradigm shift, because when we talk about social emotional development, and Dr. Ann Stone and Duggan and I were talking about this today, the concept of the individual is the concept of health. Relational is dyadic and contextual and environmental. You put those two conceptual frames together, and it has you pause for a moment and think there may be a different paradigm that's far more relationally focused, the outcomes of which become individual health focused and the like. The other thing around early relational health in action is we already have evidence-based models that are doing this work. Reach Out and Read is a classic relational health intervention. They're moving to strengthen their work to focus on parents. There's a group of Reach Out and Read people in Carolinas that are starting to bring in video feedback. My point is you already have, and for the Medicaid population, half of families in the Medicaid population experience a Reach Out and Read experience in primary care. So I already have a space to work on. Secondly, there are other programs promoting first relationships, Triple P, Alan Mendelssohn's The Video Interaction Project. There's some people that are working on early relational screening, referral, and feedback processes. My point is there are evidence-based models that focus on promoting relational health that are really in place. There's a team of colleagues that are in Michigan that are using video feedback in the medical home. They're creating what's called a little Thrive Clinic. They're inviting, before every well child visit, they're calling families and asking if they would like to come in a half hour early to make a movie and to get a little feedback. 75 to 80% of the families in the FQHCs that have this program choose to come. That tells you something important. Secondly, they get 5 to 8 minutes of video and then a little strength-based feedback. Families love it, of course. When there's a vulnerability, they're invited to come back again. And if there's and then a little more history taking can be taken. And if there's a challenge, in those clinics, they have co-located mental health services. So the point is they're starting to try to wrap around all families with this kind of relational health view. We think that there's power in a relational health concept around home visiting, the medical home, early care and education, child welfare, and we think that it may be one way to accelerate what we know through our systems if we're very intentional about that work. I want to call out, though, some cautions in the moment that I think are still a little invisible. And that is what I commented at one of our earlier meetings is, watch out for toy pollution. And the toys that have come into our culture in my lifetime are now sensory for babies. Audio and visual stim. The data shows that babies will prefer the auditory and visual stim to faces. That's part one. Part two is some research I just saw from some cultural anthropologists that are looking at this too, and looking at cross-cultural differences in parenting practices, simply looking at the use of objects. An object interaction with mothers and babies promotes cognitive and language development, but not social emotional. Whereas facial play without objects promotes social emotional development. So in this culture, we promote babies to play with objects. And we have struggles with the population-based issues of social-emotional development. I'm just curious. Are those connected? If you think from a relational health standpoint, you then start thinking about all the interferers. Think about all the disruptors to the relational context, okay? From TV, toys, not enough time together, children playing by themselves, poor quality childcare with 4 babies. I mean, think about the impact if one absorbs a relational health frame into your thinking. Now, I'll suggest these are incredibly wicked problems, meaning they're complex. But we've been working in this nation in the last 5 to 8 years to get at these complicated problems. And I'm most struck by this new conceptualization from the collective impact movement to the next steps. That for systems change, there's really 6 domains to keep your mind on at the same time. And to, when one's building community and system building, be mindful of 6 domains working simultaneously. And it's, of course, policies. That makes sense. And it's, of course, practices. That makes sense. And it's also, of course, money, because you've got to pay for people doing the work. But I would also say they call out the importance of the relationships in the communities and the importance of power dynamics. Meaning, that's the equity piece. How do you get families connected to the programs that are really valuable if there's a power dynamic that they don't trust it? So one has to be very attentive to power dynamic. But the other element I think that's been called out in system building is mindset. What's your frame of thinking about this work? And I like to believe that the relational health mindset is an element that could really unify in terms of moving us forward in this effort. We have to have a redesign of the medical home where all babies and young children are touched in this culture within the pediatric and child health sector. All families are touched. That does not extend far enough into the OB sector and to hospitals. Those connecting points between OB, peds, what some people are starting to talk about is the 3-year gestation, preconception, conception, and post as being one unit is really what's moving forward in terms of expanding our medical home. But the medical home communities are ready to advance team-based care. And there are great examples you can see across the nation that are moving to co-locate, like medical legal partnership, like Project Dulce, or Healthy Steps model, where we have a developmental specialist in the medical home, or we have an infant mental health specialist as a co-located, or we have early educators. You follow me? The co-location within the medical home, or home visiting deployed out of the medical home into the community. That kind of work is moving in terms of the concept of high functioning and performing medical home, and there's sustainability funding coming out of Medicaid to that kind of thinking moving forward. A caution, mindset. We're starting to see a dialogue in this nation about the sense of social isolation, the sense of fragmentation. David Brooks, if you follow him, has been writing about it. He's now partnered with the SEND Institute. They're the 2Gen people, to start really thinking about this hyper-individualism of our nation. You hear the words? As opposed to interdependence. Now again, early relational health is not hyper-individualism. It's really focused on interdependence of building health and being well-being. I think there's a movement that's growing around this space. There's a few examples, and I have just a few more minutes. Bridgeport Prospers is a community-led effort within Bridgeport, Connecticut, in the deepest area of poverty probably in the nation per capita. And there's been a community organizing agenda that crosses churches to neighborhoods, to communities, to health sector, to policymakers and the like. And they've been organizing with the goal collectively, a mindset of we want all of Bridgeport's babies to be ready for school. And they've begun to create a care system, what's called the Bridgeport Basics, which is a general population-based messaging about the importance of the basics of caring and well-being, as well as a universal home visiting system with Family Connects. And early literacy, Reach Out and Read, and the like being central. They've been able to community organize around their faith community and their grandparents to create what they call their army of advocates and advocates. They view that every year there's a new cohort of babies. Every year, today, there's a baby born. How do we surround them with a community messaging of we're with you and your baby's going to be ready for school? And mobilizing the community assets that are in place. They're basically using a universal home visiting connection, universal developmental screening approaches, linking to Reach Out and Read and to community libraries. They're focusing on getting the senior citizens engaged in supporting the next generation of families and local communities, preaching from the pulpit about this being a part of their community agenda building, and measuring and monitoring as they go. They're 2 years in. We'll see what happens. It's almost like the redo of the Harlem City Zone work for this century, for this moment. That kind of thinking is being galvanized across the country in other communities. Each community is its own story in that kind of effort. The Oregon landscape is taking it on as a state agenda. In Oregon, there's an intentional redesign of the policy landscape in that state, where the healthcare authority has contracted to all the MCOs in the state, and simultaneously there's been the creation of contracting for early childhood hubs, which are all the state-funded community programs that serve young families. Those two, the CCOs and the early childhood hubs, are basically partnerships. As I mentioned earlier, their job, Medicaid's job now, is to start reporting on the kindergarten readiness of their community of kids. They will have to invest in their early childhood hub in order to address social determinants of health. They're looking upstream at managing risk and trauma and addressing maternal depression. So again, it's in a population effort, policy, programs, leadership. The challenge they're going to have is engagement, but the mindset's trying to shift towards an upstream prevention promotion effort. I mentioned the integrated care model for kids that I'm going to learn more about. This resource, the ink marks, actually shows that this movement of linking Medicaid and community systems has the support of a broad range of both advocates and programs moving forward. So lastly, to advance early relational health, it's really all about thinking of 3-year gestation. It's all about focusing on dyadic relationships. It's important about thinking about breaking the generational transmission of adversity by a focus on healing, resiliency, and recovery. We got to measure, we got to be authentic, we got to ask the hard questions, we've got to be thinking about populations and communities in our work and mobilizing the people in that space. We've got to be thinking about innovation. We have to be thinking about our mindset as we go. Again, I don't have the sound, but I will promise you that my little granddaughter at age 5 weeks with her little mother, watch for the awakening of her relational health. They are in a little verbal dialogue.
Hi, who's a cute baby? Are you the cute one? Yeah.
You see it?
What?
That social smile, the very rudiments of that process, is awakening in the relationship. Babies do not develop health alone. In fact, positivity, affect, brain development, future potential is given and awakened. That's the essence of this relational health space. It creates the dreams that Dr. Harper had when he imagined, when he saw that in working with families, he knew that helping them for the future of their children and partnering with families mattered. He knew that maternal child health had to have ascendancy in order to achieve that. He understood that this was a tall order in terms of moving public health in this kind of direction. I'd like to say the future that we have to dream about is exactly that. how do we assure that the birth of every baby has the potential to achieve what their parents dream of, what their pediatricians and their home visitors and their communities dream of, but what our nation needs in terms of building well-being of the next generation. I'm really thankful to be honored to be a part of this dialogue, this great event today to celebrate Dr. Harper. And thank you again for the invitation today, and I'm happy to take any questions. Thank you.
Thanks so much. So we'll open up to questions or comments that folks may have.
So first of all, thank you so much. This was exciting and humbling to see such a cool synthesis of policy projects and baby footage. That made my day. My question is about your trend on integration of primary health care into public health. That's a passion of mine that I'm getting into. In your opinion, what is the role of primary health care teams, from community health workers to nursing staff, et cetera, in a resilience and strength-based environment where those clinical spaces have traditionally and historically been dense? What is the role of those teams in a resilience and strength-based approach?
Well, you're right on point, because I think it's primacy. I mean, I think it's essential, and I think that the primary care medical system touches all babies. Okay, so it's an access point that nobody else has. That's part one. Two, the doc and the current system cannot do it alone. Let's be clear. Three, the drivers and the supports are not in his or her office. So the linking with the community resources, the connecting points, become essential. Now, you ask the harder question, though. What happens in rural communities, right? But ask yourself the question, what's the role of technology? How do we use the technological opportunities of linking and coordinating for connecting to resources need? The other thing to be weaving, the power of home visiting as a strategy in all of its variations and forms to engage socially in the maternal child health space is still untapped, but I will suggest that that's where people are really exploring as to moving that kind of agenda forward. So it's like right in front of us, the strategies for financing structures are opening up. It really is leadership, vision, and team building activities that are, I think, right in front of us as the forefront. So it's good work. Thanks. Others? Yes.
Yeah, thank you very much. You mentioned that you thought, or I think you used the term, that it's probably universal, some of these patterns across cultures. To what extent has that actually been researched? I mean, for those of us who work internationally, how directly can we apply, for example, some of these staging, the stages that children and parents go through in the relational thing? Or do you feel like there's a program of research that still needs to be done in, lots of different cultural settings to try to see if it's...
I think the research is really thin. There's some in cultural anthropology, and that's also thin. There are a few voices out there that are working on that. I think there's a lot to learn. On the other hand, what I've seen in my reading from the cultural anthropologists, who don't have the rigor of our study, they have a more I forget the words, they're more ethnographic, more descriptive. But what's observable is that the nonverbal interactive patterns have a lot of consistency across different disciplines. It's when you bring in language and symbolic concepts and left brain language systems and culture that are more in the narrative side of the story where there are very notable differences. But if you look in the first 2 years, which are much more nonverbal patterns, there's consistencies and inconsistencies based upon the focus on either collectivity or individuality and the differences there. There's a lot to study, a lot to know, but as the Sustainable Development Goals are moving forward, one of my uneasinesses, and again, this is me speaking, my uneasiness is that too quickly that work might adopt Western culture views, And that makes me really uneasy because our health outcomes in Western culture aren't very good, especially mental health. And so I think that, the research community internationally, I would love to see some naturalistic studies that look cross-culturally, asking that kind of question to help guide as the Sustainable Development Goals and the framework of, nurturing care comes on board, especially under that, that attuned relationship work. We don't have enough science there to help us know. So it's wide open. Okay? Others? Yes.
Thank you very much. This is really interesting. My question is regarding, this early relational approach. I understand that it's obviously like in the earliest stages in life, with babies or with very young kids. But I don't know if you have any insights on what kind of approaches, or if there are any other kinds of approaches related to this. When we have older kids or teenagers that are, they already have this disruption, they have trauma.
Sure.
And they live in
We have a lot of evidence-based interventions. We have a lot of peer model supports. We have the movement that's coming in terms of, the mindfulness activities and supports. There's a lot of work. There's a lot more we can do, and we don't have enough of a workforce, and we have a lot more to learn. But I would suggest down here in the relational health space, we don't have enough learned about prevention promotion and about how you begin to scale in that space. But at older age groups, we're trying to fix where things went disrupted or use social and peer support efforts to really help support those that may have had challenges from something earlier. Okay.
Well, thank you so much. I think we're all going to join you in hopefully helping us all dream and finding those keys to success. So thanks again to the HARPER family and Dr. Willis.